Very good morning to all the doctors present here. I'm your host, Ekta Ganwani, and I'll be your host for this session. We have with us Dr. Sagar Bhargava, who will be first introducing the IOL topic to us in a brief. Sir, you may start your session, and you can also share the screen if you have any presentation.
Yeah.
Thank you so much.
Yeah. Yeah. So is my screen visible?
Yes, sir.
Yeah. So good morning, one and all. I welcome you all to this course of Premium IOL. Now, every cataract surgeon wants to upgrade to premium IOL practice after a certain period of time. And more so with the current patients profile that we have, they are so well informed that they themselves seek this solution. So how does one begin and excel in premium IOL practice? This course will essentially address this question. And when we talk about premium IOL practice, these are the things that we need to look into. So first comes the clinical assessment. Then once we are done with that, then the measurements, getting it right using appropriate formula. Then you come to what exactly is the IOL that you're going to implant for these patients. And then you can also use newer imaging systems, which will bring in superior outcomes. And ultimately, if at all doing all these things, still patients are unhappy, we need to deal with them. So this is how is the brief outline of the course. And let me first call upon Dr. Mona Bhargava. She is a senior consultant in cornea services at Shankaracharya, Kolkata, and she brings with her experience of close to 15 years. I invite Dr. Mona Bhargava to share her screen and start her presentation. Thank you.
Is my screen visible?
Not yet, ma'am. Share it.
Administrator, please allow Dr. Mona to come in. She is logged in through the faculty link.
Okay.
He is here.
Yes, it's visible now.
A very good morning to everyone. I am going to talk about eligibility for premium IOLs. So we know that past 2 decades has experienced an evolution of cataract surgery from a simple removal of cloudy lens to moreover of a refractive procedure that provides higher levels of spectacle independence. And with this evolution, there has been a parallel increase in patient expectations. So cataract surgery is now poised to compete with refractive surgery, and with improvement in technologies has set new benchmarks. My slides are not moving. So some of the red flags for premium IOLs are, as we all know, that careful patient selection not only focuses on the thorough examination and biometry, but evaluation of the patient personality traits as well. So demanding type A personality, as well as it has been seen that patient with multifocal IOL implantation with certain personality traits like neuroticism are quite unhappy with the post-op outcomes. Patient unwilling to wear glasses after surgery or patient unwilling for any surgical enhancements are not at all a good candidates. People with job requirements at night or low light conditions like airline pilots, truck or taxi drivers, astronomers are not able to tolerate glare and halos and should be excluded. It is indeed imperative to rule out the presence of a prior ocular surface disease by a careful history taking, evaluating the prior history of any presence of surface disease, any ocular prior surgeries, or use of medications with associated preservatives which can lead to ocular surface toxicity in the long run, presence of any systemic inflammatory diseases, presence of any non-ocular symptoms like dryness of mouth, fatigue, joint pain, etc., prior punctal surgeries, or history of Bell's palsy. Ocular surface disease is potentially caused to reduce visual quality and thereby affect the measurements preoperatively. So even it is imperative to rule out the presence of non-visually significant ocular surface disease by careful examination. Patient should be counseled and prophylactically treated so that to minimize the exacerbations post-surgery. And in visually significant ocular surface disease, delaying the final measurements and postponing surgery till it is fully treated is recommended. Now moving on to the clinical examination, looking at the blink quality and quantity, presence of lag of thalamus, any form of exposure, the tear meniscus height, presence of foamy secretions, presence of lid margin changes, telangiectasias, or cylindrical dandruff should be done. Another important part of examination is lifting and pulling the upper lid, which is often underlooked to rule out the presence of superior limbic keratoconjunctivitis, superior corneal scars, superior epithelial bracement membrane dystrophies, lid laxicity, or floppy eyelid syndrome. Moreover, it is imperative to identify patients with minor handy simple tools like Shermer's, TBUT, fluorescein staining. This is a short video of TBUT, which is quite simple to perform as an outpatient procedure to indeed surprise you with surface staining like this in a patient presenting with a normal ocular surface. Another important examination part is just pushing the lower lid margin to see the mebum quality and quantity with either finger or a cotton-tipped applicator to rule out presence of non-obvious MGD, which can be present without any inflammatory signs. Imaging of the Mebobian gland by infrared topographer helps us analyzing the dilated tortuous or atrophic glands and help us staging the disease severity and anticipate response to treatment. Scoring of the Mebobian gland dropouts can be done from a score to 0 to 3 to evaluate the presence or absence of these glands. keratograph, which helps us in automatic and digital measurable Mebobian glands, and a thickness of less than 60 is direct indicator with a 90% specificity of MGD. Measurement of the tear non-invasive breakup time using a Placido-based rings projected on the cornea, and the image of these rings help us in guiding and providing a color coding map where green color or cooler colors indicates a normal TBUT. Tear osmolality is also of immense importance and is one of the most sensitive tools, where measurements higher than 307 milliosmoles demonstrate loss of homeostasis, and an interdifference between two eyes of more than 8 is a hallmark of tear instability. Moving on to clinical scenarios where a pterygium with a 4 mm encroachment over the cornea like this can surprise us with the astigmatism of 8 diopters, and after surgically removing it can lead to an astigmatism value of 0.7 diopters with a regularization of the surface. Presence of recurrent corneal erosions identified by the presence of areas of negative staining on slit lamp examination, presence of epithelial basement membrane dystrophy with retroillumination techniques, and presence of punctate epithelial agents with different staining techniques help us in careful evaluation of these candidates. Presence of an inferior corneal scar like this, which might sound to be quite insignificant, can surprise us with the astigmatism of 10 diopters with a kissing bird-like pattern on the topography. Careful examination of these patients presenting with dystrophies and central cloudy dystrophy of Ancois or a predesmate dystrophy leaving out such candidates. Presence of superior corneal thinning with a ectatic cornea can surprise us on topography with a pattern of superior steepening and a thinning in the corresponding areas, and should always be ruled out by doing a tomography examination, and also to rule out any history of progressive disease. Presence of guttae on high illumination should definitely necessitate the need for doing a specular examination, where the presence or absence of cells can give us idea of the cell morphology, type, and the stage of the disease. Presence of microcystic edema on corneal examination with multiple areas of peripheral anterior synechiae can rule out presence of eye syndrome with a specular image like this. Presence of tracks-like pattern on slit lamp evaluation carefully can help us in ruling out posterior polymorphous dystrophy. Any phakic edema should be taken very carefully to rule out the presence of either infectious etiology or even for presence of atypical variant of Fuchs. Pupillary abnormalities like the presence of coloboma, which can cause glare or photosensitivity, presence of atrophic iris, or presence of eccentric pupil should always be ruled out, because they can lead to glare and photosensitivity with increased chances of zonular dialysis and multifocal IOL dysfunction later on. Presence of aniridia should be looked for. In pseudoexfoliation, the presence of subtle zonular weakness, which can be unpredictable and progressive over time, can lead to decentration, aberrations, uncorrected visual acuity, and a significant loss of practical quality of vision thereby. Astigmatism less than 1.5 with a rule, and against the rule less than 0.75 should be carefully ruled out, and irregular astigmatism should always be evaluated with a tomography examination. Uveitic patients are not at all good candidates for multifocal IOLs. Retinal issues like RP and Stargardt disease should be ruled out. Maculopathy, diabetic ARMD, ERM can cause impaired vision, reduced contrast, and thereby difficulty in fundus visualization by the treating physician with these form of IOLs. So these are strict no's. Optic nerve head diseases can lead to decreased vision and contrast and restricted visual field. presence of glaucoma suspects and ocular hypertensives with no disc or visual field damage who have been stable for a prolonged period of time should only be the selected candidates for multifocal IOL. Monocular performance in a one-eyed or a cataract surgery in one-eye patients would not achieve binocular summation, so should not be taken in. Low myopes have excellent uncorrected near vision, may face a photic phenomenon, should be carefully counseled so as to rule out, although they might adapt with time with neuroadaptation. Presence of hyperopia, the monofixation status should always be checked by a base-out prism, and these patients have disappointing visual function later on, so pre-op evaluation should be done for these patients. And a mild reduction in contrast sensitivity in amblyopes can produce a disproportionate reduction in visual function, so should be ruled out. History of prior surgery, especially in the form of post-refractive surgery, cornea itself becomes multifocal, and placing a multifocal IOL might lead to decreased contrast sensitivity and thereby decrease in visual function and increased in higher order abrasions. Evaluation of optical clarity by out. This will be dealt by Dr. Sagar Bhargava in detail in the next session. So to conclude, an aggressive and multifaceted approach to rapidly reverse OSD, thereby optimizing pre-op measurements, improving refractive outcomes, minimizing surgical delay, reducing post-op risk of infection, and thereby increasing overall patient satisfaction should be the target in all premium IOL candidates, which have a high chances of achieving a youthful form of vision. Thank you.
Thank you so much, Dr. Mona, for your talk. Dr. Sagar, do we have you next?
Yeah, I'm just sharing my screen.
All right.
Right. So is my screen visible?
Yes, sir.
Yeah. So thank Dr. Mona for her talk on clinical assessment for premium IOL patients. Now now we have evaluated these patients. Now let's get their measurements right. So basically we'll be speaking on topography, biometry, abrometry, and other measurements that come with it. So let me start my presentation with this case of a 42-year-old lady who had I had operated her left eye in 2014. Patient was not very happy, had complaints of halos, after images, and diplopia. And now she comes with the other eye surgery at 2017. Now what differently I can do? In the course of my presentation, we will understand this. So now when we talk about accuracy of our outcomes, a benchmark was given by Royal College of Ophthalmologists, which stated that at least 55% of the patients should be around plus or minus 0.5, and 85% should be around 1 diopters. But a more realistic figure in today's times would be that you should achieve about in your 50% of patients around plus minus 0.25, and in 90% of patients it should be 0.5 in order to give a very predictable outcome for your premium IOLs. Now, before you start into premium IOLs, you should assess what exactly are the tools that you have, or what would you like to have it when you are planning for such a practice. So if you have a conventional biometry, you have to look at these measurements to be taken separately, and you need to input them in your online formula. That would mean that you have to be very careful about transcript errors. Most of us and most of the newer purchases are now all-in-one biometers, which have all these measurements in one click, along with the latest formula. So you get everything in with one button click. And you have to also think about ancillary measurements, see which clinics have these instruments available nearby your clinic, so that you can get these measurements done as and when necessary. The principles remain that you should avoid putting any drops before measurement. And if at all the eyes are very dry, you have to wait for 5 minutes at least after application of the drop. Get both the eyes measurement done, even if the patient is coming for one eye. And you need to take these measurements in undilated state, because you need to understand the pupil dynamics also. So in our setup, what happens is the optometrist does the initial checkup and he diagnoses the patient to have cataract. He hands over a cataract questionnaire, which basically tells us about asks the patient to fill up, and it tells us about patient's lifestyle, his spectacle use at present, post-op expectation of spectacle use, and opinion about quality of vision. So this information is usually helpful to understand what the patient needs. So So after the patient has undergone this thing, he undergoes a manual keratometry and a biometry. Then, if it all is fit for toric and multifocal, he undergoes Varion and Pentacam. And after that, the patient undergoes IOP measurement, dilatation, and then further retinal checkup, and if required, OCT also. So these are the measurements that we are looking at if you're thinking about premium IOLs and getting the things right. Let's see one by one. The first thing that we need to see is patient has astigmatism and is a candidate for toric IOL. You should answer these 4 questions before you actually decide the patient needs a toric IOL. The first question is the magnitude and axis of astigmatism correct? Now, we all know that there are many ways of measuring corneal astigmatism. So in our place, we did a small study of about 18 eyes of all these young patients who were young interns who join us for optometry. And we basically did manual keratometry, odometry, Aladdin measurements, Varion, and IOL Master 700. And we were surprised to see the results. And if the ones which are highlighted in red, you can see that the auto K values are quite different from the other values. And the ones which are highlighted in green, you can see that the manual K is quite less than the ones which are measured by the other thing. But one thing that is there consistently is between Aladdin, Varion, and IOL Master, at least 2 of them are showing consistently same values. Now, when we come to magnitude of astigmatism, we found that 2 eyes had a significant difference in the magnitude. Similarly, axis 3 eyes showed different axes. So in short, basically, you will get different axes, different values. So what you need to look at is at least 2 out of 3 instruments should show agreement in reading. And if there is so much of variation, then it's better to identify the cause, give a lubricant treatment for a week. And if you get consistent reading, take up the patient. If you don't get, you can still take a median reading and go ahead with the treatment. Now, next question that we need to answer is whether the astigmatism is regular. Now, the best way to know this is doing a corneal topography, because it gives you an impression of the patient's cornea and tells you whether the astigmatism is regular or irregular. So this is an example of a classical with the rule, astigmatism, symmetrical bow tie, and this is against the rule, symmetrical bow tie. And these are the patterns which will give you the best predictability in terms of the outcome. And here you see asymmetric bow tie patterns and symmetrical bow tie with skewing of axis. These are the conditions where the predictability is slightly less. And of course, the topography will tell you that these are the patterns that you have to avoid doing a toric IOL. Now, next thing is whether the astigmatism that you have got is consistent or not. Let's see an example. This patient came for a cataract evaluation and underwent IOL Master 700. It gave a cylinder of 2.37 with our IOL power of 14.77 at 118.4. We called this patient for a topography, and to our surprise, the topography showed very minimal astigmatism. We repeated the IOL Master on the same day, and it came as 0.79 with the IOL power at 16. So much of difference can happen if you just rely on one machine to give you the calculation. The next comes is whether it matches with the clinical astigmatism. Here is a patient who is a 45-year-old myope who has never had used astigmatic correction, but the retinoscopic value and keratometric value shows high cylinder. So there is a retinoscopic, there is a refraction keratometry and retinoscopy mismatch. When we did this topography of this patient, we can see a hot spot here in the superior cornea, which is just encroaching the 3 millimeter zone. So most of the instruments will pick up a cylinder around here, but we have to understand that this hotspot is not producing any refractive astigmatism. Very important is that you should put all these patients in a retroillumination to pick up subtle findings like this. This is a EBMT and this is a posterior polymorphic dystrophy. Unless you put them on a retroillumination, it's very difficult to diagnose these subtle changes. In this patient had just contact lens induced scars which were causing this issue. So this patient didn't need a toric IOL. Next comes the axial length accuracy. Now we have seen generations of instruments available to us, and now it's very clear that swept source based OCT biometers are the ones which are of choice, because we are able to get biometry in majority of the cataracts. PCI based and OLCR based biometers are also there. Then comes immersion A scan, and then finally the contact A scan. So the technology has advanced, but can we leave this technology to do everything? Let me share with you an interesting case. This was a patient who had IOL Master 700 and was given the lens according to the IOL Master report, and patient developed a 14 diopter refractive surprise. The axial length shown by IOL Master was 35 millimeters, and according to that, 5 diopter lens was posted. When the measurements were repeated, it was just 21.67. And this was a case report which was published in one of the journals recently. And the reason why it happened was because there was a smeared optics on the swept source. So this authors also acknowledge that it did not really correlate with the clinical refraction of the patient. So it's very important to correlate clinically the values. Coming to the other measurements, all these measurements one has to take because all the newer IOL formulas want this. And when if you're planning to buy newer biometer setups, so you can always compare this across different things and see where exactly what things are available. So accordingly, you can take a choice. Similarly, the topographers have different things available, so you can make a choice based on that. Most important is validation of the findings that come in. So most of these biometers come with a validation criteria. For example, this is IOL Master 700. It tells you that if you get an astigmatism more than 3.5, you have to do a topography to rule out ectasia. So following the validation guidelines really improves the accuracy. Pupillometry is very important because a large pupil is not at all a candidate for multifocal IOLs, so one has to be careful. Coming to the formulas, now there is no doubt about it that the formulas essentially Virate Universal 2 is now accepted as the formula of choice, as is shown by this landmark study by Dr. Mellis, where he studied more than 8,000 eyes, and they've shown that almost 50% of the patients with Barrett achieve around 0.25. And across the axial lens from 22 to 20, from 22 to even more than 25, there were quite less errors in the thing. So if you take the gist of studies which is available now, you divide your patient into 3 groups: less than 22, 22 to 26, and more than 26. The middle group will give the best results. Almost 80 to 90% will achieve less than within 0.5, and the less than 22 and more than 26 group will give a moderate success. And these are the formulas of choice. Barrett is number 1. Kane is also there. Olsen and Hill RBF. Olsen is, of course, is a paid software, and Hill RBF works mainly for LensStar. So if you take about this IOL Master for Kane, it is also available freely online. And how it differs from Barrett is basically you need to input the sex of the patient as well as the central corneal thickness. With regard to the toric IOL, also the Barrett has kind of standardized. But the interesting part of Barrett is it gives you what is called as integrated K, wherein you can input values from different instruments, and it will give you an integrated K based on the values that you have given. And this is fairly accurate to give you the results. Coming to angle kappa, now we all know angle kappa. If the angle kappa is large, these patients will develop problems when you when you put multifocal IOLs. So, but angle kappa is difficult to measure. So only OpScan and Synaptophore can do it. So now more realistic thing is what is called as chord mu is done. And chord mu is essentially a 2-dimensional vector which measures the distance between pupillary axis, that is center of the pupil, and the visual axis. And angle alpha, more importantly, in patients with multifocal IOL, which basically measures the distance, again, 2-dimensional vector distance from the center of the limbus to the visual axis. Now, the cutoffs that are given for different machines are as shown here. With OpScan, anything more than 3 degrees is significant. For Pentagam, X decentration is of more than 0.2. With IOL Master 700, you have what is called as Chang varying chord, which if it is more than 0.6, it is significant. And with Titrace, you get angle alpha. So this is Pentagam. This is IOL Master's Chang varying chord distance 0.2. And this is iTrace, where you get angle alpha. Anything above minus 0.5, 0.6 is significant. You would avoid putting a multifocal IOL. Then you come to aberrations. Aberrations, as we all know, are basically imperfections in the eye, which leads to poor quality of vision. So you have lower order aberrations and higher order aberrations. Higher order aberrations constitute a very small percentage of total aberrations, but if they are present, they are a definite contraindication for doing multifocal surgery. This is the cutoff for higher order aberrations. So any higher order aberration, be it coma or trefoil, if it is more than 0.2 at 4 millimeters, you should be careful. And if the total higher order aberration values are more than 0.3, then it's not the patient is not a good candidate for multifocal IOL. And any spherical aberration above 0.1, it has to be treated with an aspheric IOL. So this is an example of Pentagam pre-cataract report. It will give you these 2 values. The +1 basically is the spherical aberration, and 0.4 is basically the higher order aberration. So this patient is basically post-LASIK, and they're definitely not a good candidate for multifocal. Another example of this thing from iTrace. Here you can see in the right eye, it shows a higher order aberrations around 0.3, and in the left eye it's around 0.16. And this is in the right eye. There you can see a decentered ablation which is causing this. And again, this is not a good candidate for this thing. This is Aladdin. Again, it gives you these values, RMS at higher order, and the coma. Again, this is basically a keratoconus and not fit for the procedure. Another interesting case I just want to share with you. This is basically a patient who is fit for multifocal, except when we did a higher aberration study, you can see a very high coma values here. And when we investigated this patient further, he gave a history of doing a lot of hot compresses a week prior to coming to us for a STI. And then we did nothing. We just asked the patient to come back again, and you can see that the coma values are reducing with every subsequent visit. And by 1 month, the patient was absolutely fine. So this is So this is how aberration profiling can help in deciding whether a patient is fit for the procedure or not. So this now coming back to the case with which I started. So that patient, we in the right eye, we advised to do a eye trace, and we found out that the patient has a very high angle alpha, almost 0.68. Now, because we have done multifocal in the other eye, this eye also we are committed to do multifocals. In the other eye, we had done restore. In this eye, we chose to do a Technis multifocal because the central ring of the Technis multifocal is bigger than the restore multifocal. So probably this will get tolerated better, and it happened that way. The patient did well after the surgery. So in conclusion, I would say that this checklist of the measurements should be done very carefully, and we should make sure that we don't miss on anything before we advise for our multifocal patients or for a toric patient. And even if you don't do 2 or 3 tests, it's fine. You will get a very good result. But that 1 or 2 patients who are unhappy because you have probably not done that, that's what's going to make the difference. So with this, I would like to thank you for your attention, and I'm just going to stop my screen share.
Thank you so much, Dr. Sagar. Up next, we have with us Dr. Ashok for the. I will request you to start your screen sharing. I'll also request the speakers to adhere to the time, so we also get enough time for the panel discussion.
So just to introduce Dr. Ashok Rangarajan. Dr. Ashok Rangarajan is the medical director at Chennai Center of Eye and Healthcare at Chennai. And he was with Shankaracharya for a very long time and has mentored scores of fellows, including me, with nuances of cataract surgery. In fact, when he was in Shankaracharya, Chennai, any newer technology that would come in with cataract, everybody would look up to him to try and give a feedback. He has been conducting instruction courses at ACRS conference for quite a number of years. And we are very happy and fortunate for him to have accepted our invitation. And he'll be speaking on premium eye options, what to choose. Dr. Ashok, please. Thank you.
Thank you, Dr. Sagar, and thank you very much for inviting me here, and thank you for the wonderful introduction. Is my screen visible?
Yes, sir.
Great.
It's visible.
Yeah. So there is going to be some little overlap of some of my slides with what Dr. Mona and Dr. Sagar have already mentioned. And so I have no financial disclosures. And before we begin any talk on intraocular lenses, I always wish to pay my special regards to this gentleman, Sir Harold Ridley. In my opinion, it was his work of placing an intraocular lens in 1949, which revolutionized the entire outcomes of cataract surgery today. Because whether we like it or not, as cataract surgeons, we know that the index of success of our cataract surgery is the placement of the lens in the eye, and the refractive outcome which comes out of it is what is seen by the patient as an end result. How much ever we might compliment ourselves of having done a great surgical procedure, we know that it's the lens which actually plays the trick in satisfying the patient. So somewhere because of this, we have as cataract surgeons also become refractive surgeons, and the two have merged. There is also a second negative point to this intraocular lens importance, because even the insurance company and everybody feels it's the placement of the lens which is important. We must realize that both as patients and surgeons, we must crave or try to reach an ideal situation. And we cannot, we all want an ideal situation. We want everybody to be 6x6 and n/6, and we want them to reach that on day one, and we want them to reach that with good quality vision, but it's not always achievable. So it's very important that we, one, understand the needs of the patients. We do not improve the expectations of the patients. For one thing, I do not in my practice call it a premium IOL, because the moment we say it's a premium package or a premium IOL, we have already increased their expectations. And if we fall short of that, we are not going to get a good name. So I only try to talk about the benefits of the lens which I intend placing. And I always have a disclaimer at the end of my talk by saying that the final decision on the table is mine. I might have to switch the lens because of various reasons, but the plan is to perform a cataract surgery with the placement of a particular lens. So coming to the basics, what is the material we would choose today? Definitely soft acrylic. There is no second choice because we need to have a foldable lens because we are all aiming to do 2.2 millimeter phacos or smaller incisions. And the hydrophobic surface is considered the better surface. There is immense literature available which shows that it's more biocompatible. And hydrophilic acrylic, though we all use in large numbers, have an increased chance of lens opacification, which can happen as late as 3 to 4 years. And in the design, we would always want a single piece lens to be placed. We would always want a posterior square edge because posterior square edge is known to decrease the incidence of posterior capsular opacification. Today, aspheric surface comes in the category of premium lenses because it has certain visual quality benefits. I'll come to that later. The yellow chromophore pigmentation in the intraocular lenses is something which is a little controversial. Not all literature supports its use as beneficial. Personally, I don't find much benefit with it, so I do not use it unless the patient wants it. The other thing is the last point which I have mentioned here, which is probably the most important point. And the haptic of the intraocular lens should also be considered because it's the haptic which is going to talk about the stability of the intraocular lens, and stability is paramount for getting the benefits of a premium lens, whether it is aspheric, monofocal, multifocal, or toric. So I personally feel, and there is evidence in literature to show that a modified C loop gets the best contact with the equator of the bag, and a plate haptic is good, but plate haptic in the presence of a zonular compromise or a PC compromise may not be a very stable intraocular lens to place. And the next important thing Dr. Sagar has already spoken about is get your biometry right before you decide on which premium intraocular lens you're going to use for a patient. And optical biometry is the best in today's world. If you cannot afford one or do not have one in your clinic, have an access to one. If that is absolutely not possible in the surrounding in which you're working or practicing, at least an immersion A scan definitely gives as good results in most situations like an optical biometer. But as Dr. Sagar said, it's very important that you should be able to correlate certain findings with the immersion A scan. And immersion A scan is also something which needs to be done very carefully. Contact A scan is something I would probably not at all perform in today's practice. The other important thing in today's world is not just giving the patient 6x6 and 6 vision, but also talking about an improved quality of vision. There are certain situations where we might achieve only a 6x12, but if we can give a better quality by way of better contrast, better light brightness, less photopsias, then we are giving a better vision to the patient, and doing this can be achieved by choosing the lens. So next important thing, this has also been addressed by Dr. Mona very well, that very important that we do a thorough ophthalmic evaluation of the patient and do not look at placing multifocals or trifocals in patients who might have compromised discs or macula. As you can see on the right, these are patients whom I have seen recently. These two patients had 6x6 vision and then they gradually progressed with their cataracts. But we know that post-cataract surgery, they might get 6x6, but if we should place a multifocal, we might compromise on the contrast, we might compromise on their light brightness, and we might compromise on their glare and halos. And this would have an additive effect in such situations, which will not be appreciated by them. Though you might on paper show to give them 6x6 vision post cataract surgery without glasses. So it's better to probably place a monofocal lens in these kind of clinical scenarios. This ocular surface is one thing which Dr. Mona has spoken extensively, but I just want to reiterate that it's very important that we do not miss out on meibomian gland dysfunctions and ocular surface disorders. Treat them first before we do. The second very important thing I want to stress here is, if you have a clinical scenario like the photo on the right, which shows those retinal conditions of ARMD, you must have access to an OCT. An OCT has become a very important tool in our practice today. Next to slit lamp, I would probably think an OCT is a very good tool, which ensures that the macular function and integrity is intact. If you should need, please do not hesitate to take the opinion of a retina consultant or a surface consultant before you proceed with cataract surgery. The next important thing I'd always try to understand with the patient is what is the activity they do. So look at the photos on the right. I have put a housewife's common thing is she wants to have good clear vision when she's doing her kitchen work. The young executive or a middle-aged or even a senior executive who's working on the computer and driving at night, the photo on the left, wants to have clarity of vision. So you must assure them that depending on the lens and the type of glasses you will give them post surgery, what range of vision can they achieve without glasses and what range of vision can they achieve with glasses. Very common answer I get from many of my elderly female patients is, in today's world in India, is that they don't read. We don't read, so we don't need near vision. But then this is, look at the photo on the right bottom, this old lady. Most of them are always watching something on their tab, pad or phone, which means they do have an importance of near vision. So you must educate them on that. So in asphericity has become an important component on the lens we choose. And aspheric lenses are important because it corrects the spherical aberration. Dr. Sagar has spoken about spherical aberration. So this correction of spherical aberration improves the quality of vision. The important thing is, how do you select which aspheric lens? So there are two categories of aspheric lenses available today in the premium category: the ones with zero spherical aberration and the ones with negative spherical aberration. We know that the cornea has a positive spherical aberration and the lens has a negative spherical aberration, the crystalline lens, in the young age. After the age of 40, the negative spherical aberration of the lens becomes positive. So the overall ocular positive spherical aberration increases. So when we do the cataract surgery, we have an option of putting a zero spherical aberration lens, which will keep the small positive 0.27 micron spherical aberration of the cornea intact. Or we have the option of putting a negative spherical aberration lens in the bag and nullifying the spherical aberration of the eye. So what do you gain when you leave a patient with zero spherical aberration of the eye? The good thing is it improves the contrast. So somebody who's doing a lot of night driving, as you can see here, I have put an example, would appreciate better contrast. So would preferably have a negative spherical aberration intraocular lens in their bag. But somebody who has a smaller pupil and whose spherical aberration or does not do much night driving, but wants better pseudophakic depth of focus, as let us say a housewife who's into a lot of cooking and such activities, would probably preferably have a zero spherical aberration intraocular lens in the bag, so that the remaining corneal spherical aberration is left intact. So the next thing and very important thing here is, any aspheric intraocular lens when we place, the centration must be perfect. So if you are talking about a situation like a pseudo exfoliation of the eye where you feel the bag is intact, but it's not very stable because of the zonular weakness, you're better off placing a zero aberration intraocular lens in the bag than a negative spherical aberration, because a zero spherical aberration intraocular lens accepts some amount of decentration up to 1 millimeter, whereas a negative spherical aberration lens will not accept a decentration of even 0.4 millimeter or 7 degree tilt. So these are facts which have been come out of various studies, and there is a lot of literature on the things which I'm mentioning here. So in short, when you choose an aspheric intraocular lens, for the practitioner who's beginning his high-end phaco practice, cataract surgical practice, I would say first eliminate the lower order aberrations to give good satisfaction to the patient, which means eliminate astigmatism, eliminate any spherical or spherical which is myopic or hyperopic surprises in your placement of lens, which means get your biometry correct. Number two, if you find astigmatism in the patient and the astigmatism is more than 1.5, counsel the patient to have a toric lens placed in the eye. And how will you determine if the patient has got an astigmatism of 1.5? Not with the spectacle correction, but with the K1 and K2 values, which you can very simply analyze with your autorefractometer or the manual keratometer, which all of us have in our clinics. So that is the first line which gives you the hint to educate the patient to have a toric lens. Once you clear their astigmatism, they have a good benefit with vision. And in the case of centration, if it is compromised, and if there is a biometry surprise of some spherical or myopic shift, a zero aberration intraocular lens is preferable in that case and tolerates better. So in the non-monofocal category, what all do we have? We have these diffractive multifocal lenses. You can see on the right, these apodize multiple steps. And we have the extended depth of focus lenses, which are monofocal and with multifocal. The current trifocal lenses, accommodative lenses are now a little not much in vogue because they have not shown good measure. And monofocal lenses, we can adjust the power and give them monofocus benefits. So the benefits of a multifocality are independent of ciliary body function, and thereby they are better in giving the thing visual gain. But all multifocal lenses, irrespective of the type, do give glare and halos, and that increases with the additional power which is there in them, which we must counsel the patients for. This has already been addressed by Dr. Sagar very well, that one must. I will need a minute more, Dr. Sagar, and if that is possible.
No, please go ahead, sir. We have time. We have time. Please go ahead, sir.
Yeah. So we must look at angle kappa and chord mu, since Dr. Sagar has spoken about this extensively. I will not talk about this. And I generally do not encourage a patient for multifocal lenses or trifocal lenses, even if they are keen, if I find that they have a large angle kappa or a chord mu. And the dissatisfaction and disappointment with post multifocal lenses has been well documented. So if you have done a lot of counseling preoperatively, it should be acceptable. But what I have seen is, if counseling is done well, most multifocal patients are able to accept the trade-off of glare, halos, and these problems, but they are happy that they are spectacally independent. So post-refractive surgery patients, would you use a multifocal? There is not much evidence in literature. But if they have had a low diopter correction of LASIK, you might still want to use a multifocal lens or a recent trifocal lenses after counseling that the aberration component might improve in them. So what is the extended depth of focal lenses? These lenses are basically elongating the focus of the eye to produce an extended range of vision. The good news with these EDOF lenses is that it gives a good intermediate range of vision, but near vision is not well complemented. I have found that the EDOF lenses with the micro monovision correction, it works very well in this kind of work range, where the patient wants to see the what is there on the table very clearly and distance vision clearly, and is accepting to wear near vision glasses for very fine near vision. So again, these has been discussed in detail, but I just wanted to quote Dr. Hill saying that we are creatures of habit, so we don't switch from the old SRKT formula. To get better quality end result, we must switch to the newer formulae, which is what gives good results if you're using premium intraocular lenses. These are some of the newer formulae I would use if I was aiming for the newer premium lenses. And if you don't have machines or equipment, you must try to get access to them from the nearby centers in the place where you practice. Needless to say, preoperative evaluation, I'm just stressing that it's extremely important for the end result to be good. And to conclude, personalize your A constant and move to the newer formulae, use optical biometry, chair time. Here I would probably stress on the fact that chair time is most important. And the last point is also very important, that in India, it's all out-of-pocket expenses. So when we counsel a patient for premium intraocular lens, they must find the value for it when they spend for it. Thank you very much for your patient hearing, and I apologize for the little extra time I took.
Thank you so much, sir. It was a fantastic lecture on IOL, choosing the right IOL. So we move on to the next topic. Dr. Love has come.
Yeah, I'm there.
Yeah. So I'll request Dr. Love. He's here to start his presentation. Just to give us a short introduction of Dr. Love, he's a director at BBI Foundation and Netherlands for hospitals. He's a renowned pediatric ophthalmologist in Eastern India and an excellent cataract surgeon. And he has a huge liking for technology in every sphere of life. And in this scenario, also, he was instrumental in convincing everyone to get this image guiding system that is very on. So let's hear from him and understand how it has helped him to improve his outcomes. Over to you, Dr. Love.
Thank you so much, Dr. Sagar. And I take this opportunity to speak on this topic. I think we have enough time, so we can go.
Yeah, please go ahead. We have time. We are there till 11:25.
Yeah, so what is important, what we have been struggling, I will tell you my personal experience. I've always felt that the refractive outcome, the predictability of LASIK, we have not been able to replicate in cataract surgery. So slowly we have to go to that direction. And what you see here is the refractive outcome prediction has become much better. And again, we are able to repeat it much more frequently, but still we have some way to go. Now, sources of error, what we can have is either a biometry error, astigmatism planning error. Manual marking was a big handicap till we have the digital marker, cyclorotation while doing the marking. surgical induced astigmatism, it is all personalized. If all of us have to get it calculated for our own surgeries. Size of capsular axis is again an important part of the planning, and position of the IOL. So it's few years back when we first had this machine, and my first impression was that it is such a huge cost just for the marking. And that time the impression was that it is mainly for toric IOL marking. But then there was changes in the impression when we got to know about the machine much more. And what is there is probably the keratometry is more reliable, because the number of reference points taken on the cornea for the recording is much more than the other biometry machines. So if there is a difference in keratometry of optical biometer and Varion, then many times we have to lean towards Varion findings in those cases. Predictability of post-op refraction is much better. Most of the optical biometers give you the spherical equivalent, but in digital markers, what you get is the breakup of the sphere and cylinder. So that is again very important thing when we are planning to give a good refractive outcome of the patient. And so what we got to know from surgeons who were using digital markers, they told that they have been implanting even T2 lenses after they got the digital marker with them. So that changed my impression to some extent. And if you see the utility, it is first we take the preoperatively, we take the image of the eye, then plan the surgery, and the same thing we use in our operating theater. So what we do first is the data capture, and what they do in that is acquisition of a high resolution color reference image of the eye. That the machine determines the radius, the corneal curvature of the steep and flat axis, limbus position and diameter of the cornea, pupillary position and diameter, and the corneal reflex position. So the patient information is saved, and this is the pre-op image what we take. Now comes the planning. So when we plan, we select the intraocular lens, and various IOL formulas are available in the machine. So all the formulas we can test. Then astigmatism management, toric IOL implantation, even planning related to clear corneal relaxing incisions is done, and the plan is exported. Now, just for reference, I've taken my findings in this, and what you see, the incision site is marked, the IOL formula, and most of the times it takes the Barrett formula and expected post-op refractive outcome. So in my biometry, if you see, if I use a non-toric IOL, my post-op refraction expected is plus 0.48 sphere and minus 0.5 cylinder. So, but the same thing when we go for a toric lens, so it is coming to a T3, and it exactly tells the spherical and the cylindrical component. And in my post-op refraction with toric IOL, it is coming to 0.1 sphere with 0.1 cylinder. So that gives us much more confidence when we are implanting a toric IOL. And when in the other biometers, when we are getting the spherical component, so many times the sphere and cylinder can negate themselves, and we get a small spherical component of that, and which may not be very accurate. Now, same thing when you do with other machines, what you are getting here is the spherical component in both the non-toric and toric lens. So we are not very clear about that. And when you see with the IOL master, again, in IOL master, what we are getting is the post-op refraction is the spherical equivalent of the power. So that is one of the added advantage. And while planning, this is how the machine, the interface in the OT is there. And when we are planning, you need to have an assistant which will mark your sitting position, whether we are sitting in the temporal, and based on the pre-op planning. So first, what you see is the sitting position is marked, the capsular axis is marked to 5.5 millimeter, and then we start the surgery. First, the patient registration is important, and this is another advantage. Suppose many times in our fellowship days, we used to block the wrong eye, or sometimes in OT, when the OT attendants are not very careful, they clean the wrong eye. As soon as the variant image is compared, you will get an alert that this is not matching with the pre-op image. So that error also gets minimized. And what you see here is a good 5.5 capsular axis. And this is being monitored by your assistant, who keeps on changing, or it is also available on the foot switch of the microscope most of the times. And once you implant the IOL, the centration can also be assessed quite well. If the two Purkinje's images are coming in the central circle, then it is well centered. And the accurate alignment of the toric IOL. What you see, in this patient, the axis of placement was 170 degree, and finally the centration. So this is how the machine operates. Now, I'll show just 2 short videos of how we see in the microscope. And what you see here is all the side ports. Main port has been identified. The capsular axis of 5.5 millimeter is done. The main port incision mark that corresponds with the digital marker. And once the IOL is implanted, the accurate alignment using the digital marker. And another thing, you save a lot of time in pre-op marking when we used to do it with the manual markers. In this, no pre-op marking is required. In first few cases, just to be double sure, we can do the pre-op marking with the pen and see whether it is matching with the variant or not. And my first toric multifocal, I started implanting only after we got the digital marker, because I never got the confidence with the manual marking, and we will be able to deliver with a high demanding patient who is opting for a toric multifocal IOL. So once it is done, again, the same thing is done. And in this, since it is a multifocal IOL, at the end, the centration check is also important and is must for these cases when you are using a digital marker. So another thing what we faced, and this Dr. Sagar is also aware about this patient, is the post-LASIK biometry. This is one patient, we had a post-LASIK patient, and she was so demanding that she wanted a 0 power, even the post-LASIK. And the dilemma was that in Aladdin, it was coming to +18, in Varion, it was coming to +20, and in IOL Master, it was coming to +16. But after internal discussion, Dr. Sagar suggested that we use the Shama's formula in the Aladdin, and that is what I used and got a 0 power for this patient. So this, I would say, was the limitation of the digital marker system. Post-op assessment, we can, again, after a few cases, we can do a constant optimization for ourselves and the surgical induced astigmatism. Outcome analysis, toric IOL post-op day 1, getting 6.6 is quite frequent nowadays. The number of toric conversions have increased because of the increased confidence in the system. You can also use mild astigmatism and T2 models. Toric multifocal has increased. Post-LASIK, again, is still to be seen. I'm not very confident with that. And of all that we have been using for almost 3 years now, and most of them except 3 or 4 is spot on. Thank you so much.
Thank you, Dr. Love, for an exhaustive exhaustive talk on digital marking. And I indeed also believe that this is the way to go.
It's 11 o'clock.
Yeah. So now let's move on to the last talk. And if after that, if there is time, we will do some discussion. So I call upon Dr. Prashant Srivastav for a talk on how to handle unhappy patients, a difficult talk. And Dr. Prashant is, can he share his screen, please? Dr. Prashant is there?
Prashant, you need
Yes,
to
sir, I'm
unmute.
here, sir.
Yeah.
I'm sharing.
So as he's sharing his screen, let me talk about Dr. Prashant. He's a consultant at BBR Foundation and Netherlands Group of Hospitals, and he's an extremely bright and dynamic surgeon. And he essentially did his glaucoma fellowship from Shankar Netherlands, and then continued to work in Shankar Netherlands as a consultant. He's been very active as a speaker, instructor at various ophthalmology forums. And let's hear it from him. Over to you, Prashant.
Thank you so much, sir, for a kind introduction. Is my slide visible?
Yes.
Yeah.
Okay. So first of all, thank you, Dr. Sagar, sir, for including me in this instruction course and this program. So I'll be talking about handling an unhappy patients after doing a multifocal or premium IOL. First of all, I have no financial interest in any of the technology, equipments, or the surgery which has been shown in my presentation. What is the best way to handle unhappy patients? The best way to handle an unhappy patient is not to create or not to make unhappy patients, but that's very difficult and easier said than done. So in order to achieve that, we have to do a proper counseling many times to the patient. You have to utilize the topography very well and rehabilitate ocular surface, address astigmatism. These are the 4 key things which should be done in order to not to get an unhappy patients. Now, even after following the aforementioned advice, even then also you will be getting unhappy patients in your clinic. So when you are meeting an unhappy patients, first of all, we should be listening to the patient. We should not be dismissive or defensive of their complaint. It is very critical to listen to their issues and to create a game plan to tackle those issues. Finding the root cause of the patient dissatisfaction is a key. In majority of the patients, it has been found that in majority of the patients, the only problem is the unrealistic expectations. They expect too much from a premium IOL. And most of this is because of this industry sponsored literature, which by advertisement and by poster, they showed that after putting a multifocal or putting a multifocal toric, they'll be able to see everything clearly from distance to near, and everything will be clear, and they will have no problem in their life. So expecting a superhuman-like vision after putting an IOL is something which is troublesome. In most of these patients are unhappy. Listen to them carefully, and so that you can plan your strategy to tackle the problem. And you have to make sure that you understand, make them understand that no technology is perfect and no premium IOL is perfect. Some issues will be overcome with time and with new adaptation, but some issues should be addressed properly. One of which is ocular surface disease, which is already described by Dr. Mona. So the cornea, tear film instability, and ocular surface disorder can affect the dryness, can affect the quality of life significantly, and rehabilitate ocular surface. So we have to rehabilitate the ocular surface before going for a multifocal or before going for premium IOL. And even if after the surgery, we have to continue with giving supplements to rehabilitate the surface. If you are planning a newer procedure like laser vision correction or anything, we have to rehabilitate the surface again. Few authors prefer to use cyclosporin drops before the surgery, few weeks before the surgery, and they continue it after the surgery in addition to the lubricants. I'm just holding for a second. Is it visible clearly? I cannot see myself. Okay.
Yes, sir, your screen is visible.
Once again. So the second issue to be deal with astigmatism. So for a multifocal lens to perfectly work, the optical system has to be perfect, and even the slightest amount of astigmatism can affect the vision significantly. Even 0.75 of cylinder can make a patient very unhappy. So residual astigmatism should be treated very aggressively. So this is a publication by Kazuhiro. They have shown that how experimentally induced astigmatism can affect the functional vision, and they have compared it with the functional vision and low contrast vision as compared to the conventional vision. So conventional vision is the vision that we check with Snell's chart. So even if the patient has a vision of 6 by 6 with an astigmatism of 0.5, the functional vision can be severely affected, and also the low contrast vision. So if the patient has a residual astigmatism after toric implantation, what should we do? First of all, we have to determine what is the IOL axis of the toric implantation, implanted IOL. And we can do this with the help of slit lamp, eye trace, or smartphone app. If there is misalignment, we can take the help of online calculators like astigmatism.com. If there is ideal alignment here, then we have to do a laser vision correction. This is just an example. This is a 62-year-old male patient who had a visual acuity of 6/36 with NS2 cataract, and now we can see here the patient has a cylinder power of 2. So a toric IOL was planned. So toric IOL is planned, and after the calculation, this model was suggested, and orientation of 16 degrees was suggested. After the surgery, and toric IOL was put, the vision was 6/9 with pinhole. It was improving. Refraction was 0.25 spherical and 0.5 cylinder at 70 degrees. So the axis of toric IOL was checked, and it was 28 degrees. So the ideal axis which was suggested was 16 degrees. So how to see the the placement what is the exact position of the IOL? So we can directly check it by slit lamp, but a better way or more accurate way of doing this is taking the help of smartphone app. So this is a smartphone app developed by Dr. Saurav Patwardhan. This is freely available across the Android platform in Play Store. So what you do is just ask the patient sit on slit lamp, take a picture of their IOL, and make sure the camera rotation is 0. The camera, all the mobile phones has gyroscope, so they can detect the small amount of rotation. And once the camera rotation is 0 and mark rotation is 0, take a picture, and then draw a line across your dots of the toric IOL, so that you can get the actual axis of rotation of IOL
coming.
I know, I'm trying, sir.
So once you have calculated the axis, you can go to this site called estimatingfix.com. You can put all the details of the patient. You can put the whatever residual refractive error you have got and the axis. Also put the correct spherical equivalent of the patient and originally calculated IOL axis.
6 socks hain. Pehla mera
Somewhat. Someone is talking.
Can you mute everybody, please? Excuse me. Can you mute?
Yes, sir.
Okay.
Yeah, technical team, can you mute everybody?
Yes, sir.
Yeah.
Okay.
Hello. Sorry.
Dr. Priyanka?
So you can put, and then this calculator will give you what should be the ideal axis of placement, and here it came out to be 21 degrees. So the rotation should be done to 21 degrees. So ideally, initially the calculator suggested the placement of IOL at 16 degrees. We put it at 28 degrees, and once we try to fix it with the calculator, it suggested 21 degrees, and that will have a minimal refractive error in this case. So next, if we have residual refractive error, so that was astigmatism. Now next we'll be dealing with refractive error. Even slightest amount of refractive error again will hamper near, intermediate, and distance vision. Nowadays, with the advent of newer formula like Hill RBF and Barrett formula, and with advanced biometry like IOL Master and with Pentacam, the chances of refractive surprise are very less. Even then, we have to take at least 2K readings from 2 different machines. We have 3 different machines, so we can take 2 readings from 2 different machines and compare the reading. If the measurements of K value or axial length is extreme, then you have then explain the patient that the post-op refraction, you may get surprised, and there can be a need of vision correction after surgery. So if there is a disparity in between 2 eyes, also you explain the patient that there is chances of getting a refractive surprise. If there is a high spherical error, then IOL exchange or piggyback lenses are good options. Prefer IOL exchange over piggyback lens. So IOL exchange is better than doing a piggyback lens. If there is zonal disability, then a toric IOL rotation should be avoided. Better to go for a laser vision connection. If the patient has vision is and everything is fine, but only has a difficulty in seeing near things, then we can do cyclopathic reflection to the patient. Sometimes these patients are slightly hyperopic, and they need slightly laser correction to correct this hyperopia. Unhappy multifocal patients, generally these are the 6 C's which are the cause behind the multifocal unhappy multifocal patients. The issues of cornea and cylinder is already discussed. Now the capsule. Even the slightest amount of PCO can make the patient very unhappy. Now the threshold of performing a YAG capsulotomy is slightly earlier in case of multifocal IOL, but it should be at least 6 weeks away from the date of surgery. We have to be very clear whether it is the intrinsic issue of the IOL or the PCO which is causing the problem. Because if there is an intrinsic issue of the IOL, we have to do an IOL exchange. Once we have done a YAG capsulotomy, the IOL exchange itself becomes very difficult and can have very much complications. So we have to be sure whether it is an IOL problem or it is a PCO before deciding for YAG capsulotomy or IOL exchange. Next is the issue of centration, which has been discussed by Dr. Sagar already. If there is a large angle Kappa, multifocal should be avoided. And even a slight amount of decentration can cause huge problem like flare, halo and glare and Vaseline-like vision. So in case of slight decentration, we can try laser idioplasty, but in case of large decentration, we have to do IOL explantation. So patients with pseudoexfoliation and all are not a candidate of doing a multifocal IOL. Sometimes the patient's vision is 6/6 and near vision is N6. Still, the patient is not so happy and they are not so satisfied with the vision. In such cases, we must do a macular OCT scan with SD OCT that will be able to pick up the small amount of the smallest amount of macular edema. In those patients, we have to treat with NSAID, steroids, and in some cases, it may require intravitreal injections also. Sometimes it's just craziness of the patient. So sometimes it's difficult to decide whether the patient was crazy or the doctor was crazy. If the patient was crazy and not satisfied with anything, whatever you do with the patient has a supratentorial issue, or the doctor is crazy to think that all the patients can undergo a multifocal implant. Multifocal is not a lens for everybody. And if you feel that after feel that it's nothing satisfying the patient, we can consider changing a multifocal lens to a monofocal lens. Sometimes it will not ameliorate the symptom, but the patient will be satisfied this multifocal lens is at least not the cause of the problem. Sometimes you have done a good surgery, you have done all the calculations right, your plan is almost perfect, but sometimes it is just the wrong patient who can create the problem. Sometimes the patient is not crazy, but he's just not patient to wait for some time, for the new adaptation and other things, and learn how to deal with the situation. In such patients, a quick trick to make them understand what multifocal is doing for them, and this is the best technology for them, is to put a -3 diopter lens in a trial frame and ask them to read or see the mobile. So that will make them understand that because of this multifocal lens, they are able to see their mobile, see their WhatsApp conversation very clearly. If we had gone for a monofocal IOL, they would not be able to see mobile and reading things. Though it sometimes medicine prescription cannot be seen, but it is solving the purpose greatly. In summary, in multifocal IOL have come a long way and it is evolved hugely and can provide visual rehabilitation for the patient for near, distance, intermediate, mostly. But still we have patients which will not be happy with their outcome. And if the only way to prevent this unhappy patient coming to the OPD is not to perform a multifocal or a premium IOL surgery, but that we are not going to do that. So for that, we have to do a proper counseling of the patient, take care of the surface, do calculations, repeat calculations, at least 2 sessions of counseling before planning for a multifocal lens. Once the multifocal lens unhappy patient comes to your clinic, do listen to them. Do not be defensive or dismissive to their problems. Understand the problem, treat them well. That can convert your unhappy patients to happy patients. Thank you so much for patient hearing. Thank you so much.
Thank you so much, Prashant. It was an excellent talk on how to handle unhappy patients. So we still have about 10 minutes. So I will take the advantage of this time and put some questions to our experienced surgeons here. Dr. Ashok is there?
Yeah, I'm here.
Yeah, so I would like to ask you one question, sir. See, a patient is having diabetes, but absolutely no diabetic retinopathy, is around 55-ish. Would you put a multifocal IOL in this patient?
Yes, I would. I mean, the important thing here is diabetes is not a contraindication, but diabetic retinopathy, especially maculopathy, is. So I would counsel him strongly about maintaining sugar levels. And I would also go back and see his past record. If he's somebody who's been consistently maintaining HbA1c around 7, he's a good candidate for a multifocal. He will continue to maintain. So that is very important that they should continue to maintain. Often we see diabetics with the HbA1c around 11, who are consistently indisciplined in maintaining it and just bring down their sugar values for the cataract surgery. They are a little bit of a risk. But no, diabetes is not a contraindication. We should counsel them strongly and we can go ahead and put a multifocal.
Okay, thank you.
Sagar, one question I would like to ask. Have you all, in multifocal unhappy patients, all of us have seen. Have you seen unhappy patient with eye hands?
If I can answer, no. The answer to that question is no. In fact, eye hands with a little micro monovision, I have seen a lot of patients who are spectacle independent. These are, I'm talking about not the housewives who are not actively working. I'm talking about people who are actively working and driving.
Because I had similar experience ever since it has been launched, patients were very happy. But one patient I've got stuck. She's so unhappy with visual symptoms. Vision is 6/6, but she's very unhappy. She's not happy with the vision.
Is the complaint?
Some symptoms, she's seeing something distorted like this.
No, actually, if you go back and see literature-wise, the fact that it's a negative spherical aberration, you're nullifying the spherical aberration of the eye. So thereby, she might be somebody who's not happy with the lack of depth of perception, depth of focus, and all those findings. And maybe the dysphotopsias are bothering her.
So basically, need to
mainly cutting down the pupil size by giving a trial of miotic.
Yeah, in fact, this is a classic case which you would do a eye trace to see where exactly is the problem. And if it's at IOL level, that means there is some degree of decentration that has happened. Or if it is at the corneal level, then probably the corneal spherical aberration of the patient to start with is not very high. So it has not compensated for that. So these are the two issues only. Other than that, if it is still there, then there is a problem. Then a trial of a brimonidine 0.1% would be something that we can look at, which we do routinely. A question for Dr. Love, I want to ask him one thing. That Varion, and how do you, what are the flags that you see when you see the reading and you say that this needs to be repeated? What do you see there? Because it gives an automated reading. Yeah.
Main thing is that all patients with Varion is having another biometry report also. When there is mismatch between the two, I definitely take another reading and then we decide which to take. And if the various biometry readings are matching with Varion, then we go ahead with that.
So one thing which I have experienced at Varion is that it has a lot of noise somehow that is there. And if 8 out of 10 readings are good, the 2 readings that it gives, you really have to crack your head as to why this has come and why it has so much of variation there. So there is
the other machine.
Yes. So so the technical person who's taking the measurement also has to be quite understanding about the whole thing, because that makes a huge difference. So there is a learning curve there in acquisition of the image. I want to ask one more question to the group is, would you advise a multifocal in a 45-year-old who doesn't have cataract in the other eye? Any take on that?
Yes.
Yeah, please.
Yes. No, I have done, and there is evidence in literature that uniocular multifocals do well. It fairly depends on how comfortable the patient is in understanding. But yes, it can be done and has been performed also.
There is a publication from Switzerland in pediatric unilateral cataracts also. So we are not following that, but in that paper, in pediatric unilateral cataracts, they've used multifocals.
Yeah, and anybody in the group using CTRs with toric IOL and specific cutoff or anything, which you would use a CTR to make sure that the lens is more stable in a particular set of patients?
I mean, I have done that with those pseudo exfoliation patients who have a little bit of bag laxity. Then a CTR gives it more stability. And again, the choice of lens is important. I have seen that there are some lenses, I don't want to take names here, which have better rotational stability. And that's where the haptic design comes into play. So yes, with CTR, it does help in not the ones who have zonular dialysis, but those who have zonular weakness.
Yeah, and what I found out, anything, Dr. Love, you would like to add with CTR?
Mainly with pseudo exfoliation only.
Yeah.
I think, and again, that is toric. Most of the cases I do it only on clean patients in which these complications are not there. But otherwise, pseudo exfoliation after one experience in which the patient had gone to you for the other eye, the patient came to us came to me 4 years later after the surgery, and when we dilated in the OPD, the whole lens capsule bag came in the antechamber. And then we had to remove it and do a scleral fixated eye for that.
You see, one of the advantages of doing this measurements is what we call it as white to white measurement. So though rare, some of the outliers can still have a white to white of around 12.8, 13, 13.1. It's not an unusual happening. And there are reports which suggest that anybody having more than 13 millimeters white to white would have probably a larger bag. So there probably a role of CTR might be there. And some people do implant CTRs in high myopes more than 27 millimeters of mercury, though I have not done as yet. Most of the times it is quite stable. So I think, I think most of the things we have discussed. Anything anybody would like to add? Anything? Because we still have about a couple of minutes.
Yeah,
one
just
thing,
one question.
One thing I wanted to add, like in multifocal lenses, initially when Restore was launched, we were taught that the haptic has to be at 9 o'clock, 12 o'clock and 6 o'clock. Are we following that still?
Yeah.
For the other multifocal lenses?
Yeah, I think we should follow that, because then you are kind of getting close to the visual axis as possible.
Yes.
So 6 and 12 o'clock will give you, with a slight nasal nudge, will make sure that you are at the visual axis. I think that's everybody is following that, I think, with multifocal.
Yes, sir. You were telling something?
Yeah, no, I just wanted to know, all of you, what do you do when you find an IOL needs rotation in a toric? When would you do it? You find it on day 1 or day 2 that there has been some IOL rotation of the more than 20 degrees from what you had intended to place it. So when would you re-rotate it? The timing
I would do it at 4 days, sir. 4 days. For me, it's 4 days. We check the vision refraction at 4 days. And if there is a significant rotation more than 10 degrees, I take up the patient. But having said then, we have seen patients even being rotated at 6 months also. So they kind of maintain, somehow the lens can be rotated even at 6 months. It has happened in one of our patients who did not come for glass appointment. He came after 6 months, and there was a complete mismatch of the axis. It was a complete thing. So patient was taken up for the surgery and did well after 6 months also. Patient was also absolutely happy. No, no problem at all. But we realized that it was the wrong axis. So it can be done even after 6 months. But 3-4 days is ideal, I think. I think so. Now we should hand over this hall, and I thank you, all of you, for your wonderful talks and wonderful interactions that we had. I think we had a very good session, and thank you all for being here. And I close this thing. Thank you. Thank you, Ms. Ekta, for coordination. Thank you.
Thank you so much, Dr. Sagar. Let me also take this opportunity to thank all the doctors present, and I also thank you all for your time and for your contribution to this session. Dr. Sagar Bhargava, Dr. Mona Bhargava, Dr. Ashok Rangarajan, Dr. Love Coach Dave, and Dr. Prashant Srivastava. It was a pleasure having you all here. You can all stay connected with us. We will start a new session, which is going to be very interesting as this one. And we already have a lot of doctors from the other session present over